So I would like now to open the questions and answer session. Do I have any questions from the floor or from the visual platform? Question is for Dr. Sharini. Can you elaborate more of ancillary tests when apnea tests cannot be done?
Okay, so the ancillary test is just done as an adjunct to the brain death test that you perform. So once all other signs point toward brain death, then you can do an ancillary test. They recommend either a transcranial Doppler, radionuclide imaging, or sometimes cerebral angiography. What you're looking for is no flow to the brain.
Thank you. What if in a district hospital where there's no specialist more than 3 years? So how can the brain death test be performed and be verified?
If you do not have a specialist of more than 3 years, then as far as I know, okay, it can be done by specialists who are lesser than 3 years. It's okay, you can still do it. But if you need further clarification, you can always consult the NTRC team about how to go about it. But as far as I know, yes, less than 3 years, you can still do it if there is no one else around to do the test.
It's good, true. And of course, on top of that, just in addition to that, we also, if you're coming from a district hospital, you always have your, what do you call that, referral hospital, the bigger hospital that takes care of you. So the consultant or the specialist in charge of that hospital can come over and help you with the verifications along with the existing specialist in the hospital. All right. The third question is actually, once a patient fulfills the gift criteria, can you use TIVA for organ procurement? I mean, green anesthesia.
Actually, the patient is essentially dead. It's a cadaver, right? You don't need a proper anesthesia for the patient. The reason we give inhalational or sevoflurane for the patient is just for the ischemic preconditioning, and it's a very low dose. I don't think a TIVA should be given. You know, the cost is high as well, and the patient do not need that much of anesthesia.
The MAC is only about 0.4 to 0.5 or 0.3 to 0.4 just to maintain. It's just an altruistic gift to the patient. For Dr. Kwok, okay. All right. What is your recommendation regarding fluid therapy during transplant? Is it goal-directed therapy with the help of hemodynamic monitoring or conventional fluid therapy?
So as I have mentioned, evidence shows that the advanced goal-directed monitoring using like flow track, pulse contour analysis is limited. You may use, however, there's no evidence supporting its use. So in the end, actually, we are still going clinical. But if you have SVV or PPV, it's better than CVP. I mean, but if you still want to use CVP, you do not need to aim for a very high CVP like what we used previously, like 12 to 15. For now, they say it's about 5 to 8 will be adequate.
So with the last question of the day, with the evidences that you have gone through, is it necessary to have a hemodynamic monitoring while doing kidney transplant?
So the answer is actually no. But however, if you have limited experience and not doing a renal transplant on a regular basis, you might need a dynamic monitor such as SVV or PPV to guide fluid therapy. And it also depends on the patient's condition. If the patient is otherwise young, fit patient who had just ESRF as a main issue and no other comorbidity, you know, like cardiovascular or respiratory disease, actually there is no additional benefit of using an advanced hemodynamic monitor in these patients.
I agree on with that statement because, in Selangor as well, for all the institutional disease patients, particularly the young age group patients, we do not require any hemodynamic monitorings. All right, thank you. All right, okay. Thank you very much, everyone, for being with us today. We have an early day today, 15:33. That's good. With that, we'll come back. We convene tomorrow morning for our next, for the second day of the conference. Thank you very much. Have a safe day. Don't forget to explore Putrajaya and enjoy your day today. Assalamualaikum warahmatullahi wabarakatuh and good evening.